Today's lesson is on metabolic response to injury. The second topic is the graded nature of the injury response. The graded nature of the injury response. It is important to recognize that the response to injury is graded. The more severe the injury, the greater the response. Figure 1.1 I will mention in this chapter. The concept not only applies to the physiological metabolic changes but also immunological changes or sequelae. Thus, following elective surgery of the intermediate severity, there are many to be a transient and modest rise in the temperature, heart rate, respiratory rate, energy expenditure, and peripheral white cell content. Following major trauma sepsis, that changes are accentuated, resulting in a systematic inflammatory response syndrome (SIRS), hypermetabolism, marked catabolism, shock, and even multiple organ dysfunction (MODS). It is important to recognize that genetic variability plays a key role in determining the intensity of the inflammatory response. Moreover, in certain circumstances, the severity of injury does not lead to a simple dose dependent metabolic response, but rather leads to quantitatively different responses. Not only is the metabolic response graded, but it also evolves with time. In particular, the immunological sequelae of major injury evolve from pro-inflammatory state driven primarily by the innate immune system, macrophages, neutrophils, dendritic cells into a compensatory anti-inflammatory response syndrome (CARS), characterized by suppressed immunity and diminished resistance to infection. In patients who develop infective complications, the latter will drive ongoing system inflammation, the acute phase response, and continued catabolism. The next topic is on the mediators of the metabolic response to injury. What are the mediators of the metabolic response to injury? The classical neuroendocrine pathways of the stress response consist of afferent nociceptive neurons, the spinal cord, thalamus, hypothalamus, and pituitary. Figure 1.2. Cortico, corti, Corticotrophin releasing factor (CRF) released from the hypothalamus increases adrenocorticotropic hormone (ACTH) released from the anterior pituitary (ACTH), then acts on the adrenals to increase the secretion of the cortisol. Hypothalamic activation of the sympathetic nervous system causes release of adrenaline and also stimulates release of glucagon. Intravenous infusion of a cocktail of these counter-regulatory hormones, glucagon, glucocorticoids, and catecholamines, reproduces many aspects of the metabolic response to injury. There are, however, many other players including alteration in insulin release and sensitivity, hypersecretion of prolactin and growth hormones (GH), is the presence of low circulatory insulin like growth factor 1 (IGF-1), and inactivation of peripheral thyroid hormones and gonadal function. Of note, GH has a direct lymphatic, insulin antagonizing, and pro-inflammatory properties. Summary 1.2. A neuroendocrine response to injury or critical illness. The neuroendocrine response to severe injury, critical illness is biphasic. Acute phase, characterized by an actively secreting pituitary and elevated counter-regulatory hormone, cortisol, glucagon, adrenaline. Changes are thought to be beneficial to short-term survival. Chronic phase, associated with hypothalamic suppression and low serum levels of the respective target organ hormones. Changes contribute to chronic wasting. The innate immune system, principally macrophages, interacts in the complex manner with the adaptive immune system, T cells and B cells, in co-generating the metabolic response to injury. Figure 1.2. Pro-inflammatory cytokines including interleukin 1, 2, 1, tumor narcosis factor alpha, TNF alpha, IL-6 and IL-8 are the produced within the first 24 hours and act directly on the hypothalamus to cause pyrexia. Such cytokines also augment the hypothalamic stress response and act directly on skeletal muscle to induce proteolysis with while including acute phase protein production in the liver. Pro-inflammatory cytokines also play a complex role in the development of the peripheral insulin resistance. Other important pro-inflammatory mediators including nitric oxide (NO), I will the integrated response to surgical injury first 24 to 48 hours. There is a complex interplay between the neuroendocrine stress response and the pro-inflammatory cytokine response of the innate immune system. Okay, so this is the picture I will mention here on the below. Nitrous oxide via inductible nitric oxide synthesis, INOS, and variety of prostanoids via cyclooxygenase 2 COX-2, changes in oxygen function, that is renal hypoperfusion impairment, may be induced by excessive vasoconstriction via endogenous factors such as endothelin 1 within hours of the regulation of pro-inflammatory cytokines. uh, Endogenous cytokine antagonists enter the circulation, that is interleukin 1 receptor antagonist, IL 1RA, and TNF soluble receptors TNF SR55 and 75, and act to control the pro-inflammatory response. A complex further series of adaptive changes includes the development of Th type counter-inflammatory response regulated by IL-4, 5, 9 and 13, and transforming growth factor beta, TGF-beta, which if accentuated and prolonged in critical illness is characterized as the cause and result in immunosuppression and in increased susceptibility to opportunistic no, nosocomial infection within inflamed tissue. The duration and magnitude of the acute inflammation as well as the return to homeostasis are influenced by a group of local mediators known as specialized pro resolving mediators (SPM) that include essential fatty acid derived lipoxins, resolvins, protextins, and maricins. These endogenous resolution and agonist orchestra in the uptake the clearance of apoptotic polymononuclear neutrophils and microbial particles, reduce pro-inflammatory cytokines and lipid mediators, as well as exchanging the removal of cellular debris in the inflammatory milieu. Thus, both at the systematic level, endogenous cytokine antagonists see above at the local tissue level, the body attempts to limit, resolve inflammation driven dihomeostasis. Summary: what is box is 1.3. Systematic inflammatory response syndrome following major injury is driven initially by pro-inflammatory cytokines, that is IL-1, IL-6 and INF alpha, is followed by rapidly by increased plasma levels of the cytokine antagonists and soluble receptor, that is IL-1RA, TNF, SR. If prolonged or excessive, may evolve into a counter-inflammatory response syndrome. There are many complex interactions among the neuroendocrine, cytokine, and metabolistic axes. For example, although cortisol is a immunosuppressive at high levels, it acts synergistically with IL-6 to promote the heptic active phase response. ACTH released is enhanced by pro-inflammatory cytokines and nor-endogenic system. The resulting rise of cortisol level may form a weak feedback loop attempting to limit the pro-inflammatory stress response. Finally, hyperglycemia may aggravate the inflammatory response via substrate overflow in mitochondria, causing the formation of excess oxygen free radicals and also altering gene expression to enhance cytokine production. At the molecular level, the changes are accompanying system inflammation are extremely complex. In a recent study using network-based analysis of changes in mRNA expression in leukocytes following exposure to endotoxin, there are changes in the expression of more than 3,700 genes, with over half showing decreased expression and remainder increased expression. The cell surface receptors, signaling mechanism, and transcription factors that initiate these events are also complex, but an early and important player involves the nuclear factor kappa B, NFKB, REL A family of transcription factors. A simplified model of current understanding of event within skeletal muscle is shown in figure 1.3. The now next topic is the metabolic stress response to surgery and trauma, the EBV and flow model. In the natural world, if an animal is injured, it displays a characteristic response which includes immobility, anoxia, and catabolism. Summary box 1.4. Psychological response to physiological response to injury. The natural response to injury includes immobility or rest, anoxia, catabolism. The changes that are designed to aid survival of the moderate injury in the absence of medical intervention. In 1930, Sir David Cockburn divided the metabolic response to injury in humans into EBV and flow phases. Figure 1.4. The EBV phase begins at the time of injury. The lasts for approximately 24 to 48 hours. It may be attenuated by the proper resuscitation but not completely abolished. The EBV phase is characterized by hypovolemia, decreased basal metabolic rate and reduced cardiac output, hypothermia and lactic acidosis. The predominant hormones regulating the EBV phase are catecholamines, cortisol and aldosterone. Following activation of the renin and antagonistin system, the magnitude of the neuroendocrine response depends on the degree of blood loss and the stimulation of somatic afferent nerves at the site of injury. The physiological role of the EBV phase is to conserve both circulating volume and energy stored for recovery and repair. Following resuscitation, the EBV phase evolves into hypermetabolic flow phase, which corresponds to SIRS. The phase involves the mobilization of body energy stores for recovery and repair and the subsequent replacement of lost or damaged tissue. It is characterized by tissue oedema from vasodilation and increased capillary leakage, increased basal metabolic rate, hypermetabolism, increased cardiac output, raised body temperature, leukocytosis, increased oxygen consumption, and increased gluconeogenesis. The flow phase may be subdivided into initial catabolic phase lasting approximately 3 to 10 days, following by the anabolic phase, which may last for weeks in extensive recovery and repair the required following serious injury. During the catabolic phase, the increased production of counter-regulatory hormones, including the catecholamines, cortisol, insulin, and glucagon, and inflammatory cytokines. Figure 1.3. The metacatabolic and anabolic signaling pathways involve a skeletal muscle homeostasis FOXO4 box subgroup O mTOR mechanism target of the rapamycin myod D myogenic differentiation factor D NFKB nuclear kappa phosphatidylcholinol and 3 kinase P70S6K P70X6 kinase TNF alpha tumor narcosis factor alpha 4E BP1 eukaryotic initiation translation factor 4e binding protein 1, that is IL-1, IL-6 and INF alpha, results in significant fat and protein mobilization, leading to significant weight loss and increased urinary nitrogen excretion. The increased production of the insulin at the time of associated with significant insulin resistance, and therefore injured patients often exhibit poor glycemic control. The combination of the pronounced of prolonged catabolism in association with the insulin resistance places patients within the phase at increased risk of complication. Obviously, the development of complication will further aggressive the neuroendocrine and inflammatory stress response, thus creating a vicious catabolic circle. Summary box 1.2. Purpose of the neuroendocrine changes following injury. To constellation of the neuroendocrine changes following injury acts to provide essential substrates for survival, postpone the anabolism, optimize host defense. These changes may be helpful in the short term but may be harmful in the long term, especially to the severely injured patient who would otherwise not have survived without medical intervention. Thank you for joining the class, and we will learn next day key catabolist element of the flow phase of the metabolic stress response. Thank you.